Good morning, Med Center. Happy Friday. Also, happy Mother's Day to all you wonderful mothers out there. I want to thank everyone who was out yesterday evening for the Heroes Thanking Heroes event. It was a tremendous turnout event. It brought everyone together. There was a sense of camaraderie and great spirit. So thank you all for that. I want to also highlight something. It really is an honor to be part of a medical center that is providing cutting-edge care to our community. And I want to share an example that I learned of yesterday. Dr. Bowdish here at the medical center is leading a clinical trial that is a national clinical trial to enroll patients with COVID, with acute respiratory distress syndrome, and using stem cells as a treatment for that. And we have enrolled 4 patients here at the medical center. Nationally, they've enrolled 8 patients. So that gives you a sense of the amazing work that is happening here. And we hope we learn something from this clinical trial. Today at 11 o'clock out in the breezeway, BAPS Charities has donated 8,000 fresh meals to our employees. We expect to have some elected officials here helping distribute the meals. BAPS Charities also donated 1,095 masks and 300 face shields to the medical center. So we want to thank BAPS Charities for that. Although I really believed in all of you, to answer the trivia question, you have let me down once again. And I want to give you a clue that the longest length of stay of an individual in our medical center is much longer than anyone has guessed. So I will leave it open just until the end of this session for all of you to try to guess again, and we will announce the winner at the end. With that, Dr. Brad Spelberg.
Thank you, Mr. Orozco. Happy Friday. Time for soothing thoughts for the weekend. I do think that our staff in the hospital are adapting to our new norm. We, for 3 weeks now, have been essentially at steady state so that our outflow has been matching our inflow. The hot spot in the hospital continues to be in the ICU. The PCU now is also filling up. So we still have more than 100 open ward beds, but the ICUs, that's where we're starting to really become heavily impacted. Yesterday, there were 20 positives at our hospital, 20 new positives, but we discharged 20 patients. So we ended up net negative despite having 20 new positive tests. That shows the adaptation that has happened and the hard work of all of our staff in moving people continuously through our system. We do need to continue to emphasize rapidly moving people through the ICU and PCU levels of care, because the impaction to the ICU is what is precluding us from being able to open up other services at the medical center. And until we have more of a cushion in the ICU, we're not going to be able to open up to more clinic visits and elective surgical procedures. We continue to have adequate PPE. We have more than a 30-day supply of N95s, surgical masks, 60-day supply of face shields. So not short on PPE. We're doing 100 tests a day now, so our testing is going strong. So overall, things are going well. We're adapting to our new sort of reality. Steady state is being matched. We hope we see some slowdown in cases, but that'll be for the future to determine. And with that, Dr. Holtum, anything you'd like to add?
Thank you. Very, very little. I know that we've been working extraordinarily hard for the last many weeks in terms of protection, both for patients as well as for staff, and using personal protective equipment appropriately. What has been happening over the last week is that amazingly, patients who don't have COVID have begun coming to our hospital. And we're seeing more and more non-COVID patients, that is what was the norm 2 months ago, who are coming in with a variety of other illnesses. And we need to start rethinking back to the thoughts that we had as to how we do personal protection for non-COVID patients, not just the things that we do for COVID patients. So we need to be attuned and thoughtful that non-COVID patients also may have communicable illnesses, that we need to do appropriate PPE when we see non-COVID patients, not what we need to do with COVID patients, but what we used to do in the dim, distant past of, say, January.
Great. Let's get to the first question. When and if the stay-at-home order is lifted on May 15th, will the hospital and all of its clinics plan to reopen that day?
So the hospital never closed, of course. We are open to admissions as we would have been at any time. There's no stopping admissions to the hospital. It is, as alluded to, really the clinic situation and elective procedures. And unfortunately, as I alluded to a minute ago, until our ICU situation is more under control, or at least until we know what the impact of reopening is going to be on the ICU, we're not in a position to open up to elective procedures or do a lot more face-to-face clinic visits. If, when the Safer at Home lifts in a gradual way, people do maintain physical distancing and wearing masks and washing hands so there isn't a spike up in cases, then I think we will be able to begin really looking at reopening those other services.
I was wondering how the city of LA is testing everyone, symptoms or no symptoms, while we do not have enough test kits in the emergency room for our patients.
So I take a little bit of issue with the question because our goal of testing is very different than the goal that the city has. We have test suppliers that are different than those that the city has. And as I mentioned, we're doing 100 tests a day for one hospital. That's a lot of tests. You know, we're testing all admissions to the hospital now. We've really opened things up. So I don't know who the city's vendor is. It's doing it for different reasons. We could expand our testing more if we were happy waiting 5 days to get a test result back. That's not going to work for our patients in our hospital. So you're driving through and you can wait 4 or 5 days for a test, you're going to have a completely different setup than the tests we have in the hospital. I don't know if there's anything else.
I would emphasize the test that they're doing is different. They're not doing nasopharyngeal swabs for the city. They're doing oral or saliva. It's a different test. It has different parameters. And as Dr. Spellberg said, we don't do that kind of a test. Our vendors are for a more sensitive test, the nasopharyngeal swab. We're doing it for all patients who are being admitted right now. Arguably, the information you would get from testing a patient who is going home is relatively small. All of those patients are instructed whether or not they have COVID. If they have cough and fever, they're supposed to stay in self-isolation because whatever it is that they have is communicable.
Does the COVID affect a fetus if the mother tests positive but is asymptomatic or has a full-blown COVID?
Well, no one knows that. There was a small case series just recently put out from China that looked at pregnant mothers who had COVID and found no fetal abnormalities associated with it. We don't know because that was a small case series. I think we'll continue to learn as the pandemic goes on.
Have you all been tested for COVID?
No, I have not had symptoms and therefore not had to be tested.
I have the same answer. I've not been symptomatic. There's no purpose in testing.
That's a personal question. No, I have not been tested. What is the fastest recovery you have seen from COVID positive patients here at LAC+USC?
I think it, to some extent, depends on what is meant by recovery. Paul and I discussed this briefly a few minutes ago. I would think that you're looking at probably a week for even a mild case to run its course.
And it, of course, depends on what you mean by here at USC. Do you mean people who are hospitalized, or do you mean people who were in the ED? Because we have many, many people each day who come into the ED, some of whom test positive but improve in the ED and don't need admission. Improve, however, does not mean recovery. Most of the information that we've seen is at least a week and possibly more. If you mean full symptom recovery, that is lack of cough, then the answer is probably longer than that, several weeks for most people.
Dr. Spellberg, how do you feel about LA reopening partially today?
Yes, exactly. Yes. How do I feel about it? I do not envy political leaders' task to balance the real risk of physical harm from the virus from reopening against the real risk of socioeconomic harm, which is very tangible to individuals, communities, the entire county, the entire state, if we don't do some form of reopening. There is a need to take the yin-yang approach we discussed on Wednesday. We really should put a yin-yang up there.
Sure, this one
Right over there. Yeah. That, socioeconomic factors, the social determinants of health, are probably bigger impacts on population-based welfare and health than medical treatment is. We've seen the state of California go from a $21 billion surplus to a $55 billion deficit in 12 months. There was real harm from not allowing any form of business activities to go on. I am worried that we have 35 ICU positive patients right now. Is that going to go up? We just don't know. I think the point is we need to be cautious and thoughtful, and we need to react to local conditions. If we reopen and cases spike and there's a surge in the ICUs, we will likely have to close back down. If we are a civilization that has put human beings on the moon. We've sent space probes to Mars. We have more computing power in our pockets today than NASA had in a giant supercomputer room 40 years ago. Surely we can find innovative ways, creative ways, to not spit on each other in public while buying goods and services in stores. That's really going to be the key. If our ingenuity can come up with ways to mitigate spread while cautiously and carefully reopening the economy, then we will succeed. I guess that's where I'm at right now personally. Others.
Personally, I felt very sad this morning when there was more traffic on the road.
Yes.
But I suppose that is a more narcissistic, personal thing,
Yes.
as opposed to looking at the economy as a whole.
This is true.
What are the chances to spread COVID while wearing a cloth mask?
Would you like to start on that one, Dr. Holton?
Well, the purpose of a cloth mask, or a mask in general that someone who is symptomatic would be wearing, is to catch and prevent droplets that are coming out of the mouth while they are coughing or sneezing or the like. In that sense, as we decrease the number of droplets, that decreases probably the risk that one has of transmission. For someone who is non-infected, of course, there's no risk of transmission, and therefore the cloth mask does nothing.
Yeah, the cloth mask benefit is theoretical. There are no studies that show that wearing cloth masks reduces transmission. It seems intuitive that if we cover our mouth and nose, it will decrease the spread of droplets. So it may well help us do that, but it certainly isn't taking anything to zero. So it probably reduces but does not eliminate droplet transmission.
Has the possible treatment that Dr. Fauci mentioned gained traction?
I will start. So I think what is being referred to here is a drug called remdesivir, because of course Dr. Fauci and others have talked about many treatments, the latest being remdesivir. Remdesivir has had 2 randomized controlled trials conducted for which some results are available. The first is actually fully available. It's a smaller study. I think it was around 100 patients total, or maybe it was even 60 patients total, and it did not work. There was no benefit. In a larger 1,000 patient study, there has been a leak of data. The full data set is not available. We have not been able to do actual scientific review of the results. It did not reduce death, but it allegedly reduced time to improvement, but we don't know what improvement means. The study had an extremely complex definition of improvement. It's not as simple as saying, oh, these people got to leave the hospital faster. That was not at all the study definition. Based on that early promising signal, which has been leaked, the FDA released an emergency use authorization. Please realize that is not an FDA approval of the drug. That is the FDA saying we recognize there's a public health emergency. This drug may be of some benefit. Go ahead and use it until we've seen the full data set and can make a decision. But the utilization of it is allocated by the federal government. And at this point, I'll turn it over to Paul.
So remdesivir is not currently available for anyone to order. The company that makes it, Gilead, turned over their stock. I think it was some 1-point-something million doses of the drug to a government consortium that is going to allocate that to hospitals. To the best of my knowledge, no hospital has yet received anything from that allocation. Our hospital is in discussion with that group. There was an assigned group that the government has made of hospitals that will get the first allocations. We don't know if we're in that assignment. When and if that drug becomes available to us, we will then be using it in appropriate patients.
Dr. Spellberg, what medication that has not been tested yet would you be interested in that could help?
As infectious disease experts, there are very few acute viral infections. We'll talk about those that cause acute harm, for which any therapeutic has ever been shown to be meaningful. I can really only think of one, which is acyclovir for herpes encephalitis. I never put much stock in therapy for this disease. To me, the goal, the singular goal, by far the overriding goal, is prevention. So my answer to that question is a vaccine. I want vaccine candidates. I want to test them as soon as possible, and I will be signing up as soon as all of us can to get my vaccine. I am skeptical that any individual therapy is going to markedly improve the outcomes of patients, just because the experience over 100 years in infectious diseases is acute viral infections are very difficult to alter the course of with some kind of treatment that starts after you get the infection. You want to add anything?
I would agree with that, even for something like influenza, where a drug that's been available for some time, oseltamivir, has some utility. There are still many deaths from influenza, although oseltamivir is readily available. The biggest thing that makes a difference in the mortality of influenza is vaccination.
This is DNT GI Special Procedures. As of now, we currently have a full slate of appointments scheduled for May 18th. Will all patients be required COVID testing prior to their procedure?
DHS is currently developing I don't know if you'd call it it might be a modification to the testing expected practice. For dealing with this question, I received some language last night, which I sent to chiefs of affected services. Dr. Buxbaum was on the email list. As we get feedback back from our people, we will send that feedback downtown so that hopefully there will become an agreed upon method of addressing this issue. So I don't have I don't have an answer today on that. It's being looked at. I don't know if you have any further information from your...
There will not be increase available for in-house testing. most of the plans would be that the patients who would be undergoing procedures like this would be coming in a few days before in order to get testing that can be sent out and then resulted by the time of procedure.
Yeah. Is it true that blood thinners could help patients who are severely ill with COVID-19? A new study suggests that patients in New York City who got anticoagulants were less likely to die of the disease.
Yes. This is a matter of a lot of debate. In fact, I was on the phone with a good friend of mine who's the chief of pulmonary critical care at MedStar in DC earlier today, Dr. Andy Shore. And he pointed out to me, anticoagulants have been studied extensively in sepsis, ARDS, and other related forms of clotting in the setting of infection for many years in rigorous randomized controlled trials and not really been shown to be effective. In fact, they are actually harmful in those settings. I'm going to sort of repeat a warning I've been alluding to, but try to be explicit. We're in a very strange time in the world, obviously, right? No duh, right? That life is weird right now. Life is just as weird in academic medicine, in science, as it is in the rest of our world. The number of studies coming out, the quality of those studies, the release of information via leaked sources, pre-release before peer review is all very disheartening, frankly. So I would just urge people not to react to the latest headline that's been splashed across 24-hour-a-day news cycles. This is the time for a thoughtful approach to not make matters worse. Remember the initial maximum of the Hippocratic Oath that physicians take. In Latin, it's primum non nocere. It means first, do no harm. Our field has a long history of hurting people. You could go back to mercury, giving mercury to everybody as a magical cure-all, bleeding people to death as magical cure-alls. It is important that we not react to what are really hypothesis-generating studies. These are interesting studies that come out and make us go, maybe we need to do a rigorous and well-controlled randomized controlled trial to see if this will work before we rush to jump on the bandwagon and start giving it to everyone, especially with something that's very dangerous, like a blood thinner. That doesn't mean it won't be of benefit. It means before we start throwing it at everybody, we need to study it to know if its net benefit is better than its net harm. Do you have any?
Two things. One is that people have seen, and it has been seen here, that in some patients who have severe COVID infection, they appear to have clotting problems. And some of our patients are being treated with anticoagulants because of those clotting problems. The second, however, which is more a philosophic question, is the word study, which we've thrown around a lot, not only today, but in many of our town hall meetings in questions. In ancient days, that would be January of 2020. In ancient days, the word study meant that someone had actually sat down with a hypothesis, done some sort of testing, written something up, it had gone to a journal, peers, that is, people who were knowledgeable in the field, reviewed the information to see that the information was written, the study was done, and actually concluded what the study said. And after that, it was published, and then we said a study has been published that says such and such. As of today, you can write up anything, send it in to many journals, and get it published online within days, with minimum review by anyone, as long as you have the word COVID in the title. Were I to write a study on osteomyelitis, it will still take me months to get it reviewed and published in a journal. But if I say osteomyelitis in a patient with COVID, I will get it online with no review in days. That means that the information that's coming out is all preliminary. So the word study doesn't quite mean what it did a long time ago.
Med Center, I believed in you and you came through. Patient Charlie was in our hospital for 23 years. And congratulations to Candidly Kim, who came up with the answer 23 years and 7 months, you will be receiving a $20 gift card to our CARES Cafe. I want to thank all of our nurses. This is Nurse Appreciation Week, for their amazing work that they do every single day here at the Medical Center. And we have a brief video to show you about the celebration of our nurse heroes and our Nurse of the Year winners.
Hi, my favorite thing about working at LAC+USC is
My favorite thing about working at LAC+USC is
My favorite part about being an LAC+USC nurse.
My favorite routine of being a nurse at LAC+USC Medical Center is
What I love the most about working here at LAC+USC Medical Center is the community that we serve, and most importantly, all the nurses that I'm surrounded by. It's definitely, it's been an honor to be a nurse during these difficult times.
see the group of nurses that I get to work with. I think they're fabulous, and I feel very lucky to be working in a place with wonderful people.
being part of an amazing team that cares for premature babies, newborns, pediatrics, adults, and we do that together. Hashtag LAC+USC Pediatrics, hashtag County Strong.
Is seeing the satisfaction on patients' faces.
My favorite thing about being a nurse at LAC+USC is our commitment to compassionate care for behavioral health patients.
Working at LAC+USC as a nurse is being able to care for the underserved population.
My favorite thing about being a nurse at LAC+USC is cultural diversity and building rapport with patients and teamwork.
The favorite part about being a nurse at LAC+USC is the community we serve.
It's the love and kindness that we provide to our patients.
Providing high quality medical care to our community.
Working multicultural people. Our wonderful bonds with each. The community where we grew up. That's what makes our friendship. We are a big family. Teamwork. Yay!
My favorite thing about being a nurse here at LAC+USC is the teamwork. We have such outstanding and awesome teamwork with each other, between the nurses and also between the doctors and the nurses and then all of the staff. It increases morale, and I'm really honored to be a nurse